Hello, everyone. I'm Vasileios Lampos, a Principal Research Fellow at the Department of Computer Science. And today I'll try to provide a brief overview of some of our research in the past few years, focused on developing solutions for epidemiology that do not follow a conventional path. Let's begin with a few words about our identity. We are based at UCL Computer Science and the AI Center, but we also collaborate with public health experts from other UCL departments and universities. We work closely with Public Health England, which means sometimes our research can find practical applications. We also have strong support from Microsoft Research and Google, both in terms of research, but also as our main data providers. Last but not least, we are active members of the iSense and VirusWatch projects, and our research is funded by the EPSRC, the MRC, and generous donations by Google. So Wikipedia tells us that epidemiology is the study and analysis of the distribution, patterns, and determinants of health and disease conditions in defined populations. Now, what I refer to as traditional or conventional epidemiology relates to the origin of the data streams used by it. Its main source of information comes from our interaction with health services, be it a visit to our GP or a diagnostic. So depending on the condition under investigation, the associated information that can be used by epidemiological systems could face specific limitations. For example, influenza prevalence is often measured by the rate of flu-related doctor visits. However, most adults won't present themselves to a GP when they have flu-like symptoms. In addition, such a metric will most certainly face reporting latencies, as the time of presentation to a doctor happens after the symptom onset, plus more time might be needed to aggregate all this information from different GP practices. So in this example, some outputs may be biased towards specific subpopulations and also come late. So if we add a pandemic into that equation, whereby people were not encouraged to visit their GP, you can understand that these systems can be severely impacted. And what happens when no established health system exists to gather this information at all? So in our research, we use online user activity, web searches, and social media as an alternative source of information for epidemiology. That way, we get to access larger or different parts of the population. And this provides a complementary snapshot to what conventional approaches can offer. We can make inferences almost in real time. These solutions are relatively low cost, are not affected by closure days, and are not affected, at least in the same way, during a pandemic. What's more, methods based on online user activity are applicable to any location with a respectable internet penetration. A new challenge, though, is that the information that we look for may be implied or hidden in a temporal pattern. The data was not produced with epidemiology in mind. Therefore, the methodological approach is different compared to traditional epidemiology. And now our main tools become natural language processing and machine learning, or in short, AI. Here's an example of non-traditional epidemiology that you're probably aware of. The intuition is the following. If web searches are indicative of a health status of a user, then at national scale, the frequency of certain search queries could be indicative of the rate of a disease. Gunther Eisenbach and others proposed this first, but Google Flu Trends was the most popular application of this paradigm. Google Flu Trends is a supervised learning model that maps the frequency of certain web searches to influenza-like illness rates. However, the estimates from Google Flu Trends were reportedly problematic. For example, it estimated flu rates in the United States that were 2 times higher than the ones reported by CDC during the 11-12 flu season. Although this fueled a widespread criticism of big data models, we simply thought at the time that we can make this work by focusing our efforts on improving the machine learning model. So in collaboration with Google, we conducted a long-term analysis of the Google Flu Trends estimates spanning 5 flu seasons in the US. And you can see them with the red color in this plot. The black color denotes the ground truth from CDC. And we concluded that its estimates were indeed quite unstable. During the 11-12 flu season, we saw that automatically selected searches that are not related to flu, such as RSV, are responsible for 25% of the prediction signal during the peak period. And again, we thought that this can be fixed. So we revised feature selection, the process of deciding which search queries to use in a prediction model, and the machine learning model itself, formulating a Gaussian process that can capture nonlinearities in the relationship between search and disease trends. The accuracy of the estimates improved by 42%. And by introducing autoregression, which in our case means to feed reported flu rates by CDC back to the model with a temporal delay of 1 or 2 weeks, we're able to obtain very accurate estimates that were significantly better than deploying autoregression on CDC data alone or compared to an autoregressive version of Google Flu Trends. In follow-up work, we focused on the task of selecting search queries for these models. More exploratory experiments indicated that our models were still exposed to making inaccurate estimates due to spurious search query selections. Take England as an example. Our estimates, depicted here using red, especially during the first testing period, are not ideal. In fact, our approach was sometimes selecting names of people or companies as features. To resolve this issue, we proposed a method for considering linguistic or semantic properties of a search query during the selection process. That way, we're able to remove most spurious or confounding searches and improve prediction accuracy by 12%. Previous work assumed that we have all the data we need to train a model, but in reality, that's not always the case. Recall that during COVID-19 lockdowns, people were not encouraged to visit their GPs, for example, or sometimes a natural disaster may have the same effect, or some locations may have limited resources, resulting in more sporadic health reports. Here we show that multitask learning methods, whereby we jointly learn flu models based on web search activity for multiple subregions of a country, can offer stable solutions under these circumstances. Our experiments conducted on US subregions first show that multitask learning yields reliable estimates, even when we reduce historical data from 5 to just 1 year, and the right top chart depicts that. Then the right bottom chart shows that the prediction accuracy of multitask learning models remains stable as an increasing amount of temporally consecutive data blocks are removed from the training data. We were also quite excited to show that we can train a model for flu based on web search activity in a source country and then transfer it to a target country without calibrating the transfer using ground truth from the target country. In these figures, you can see transferred estimates with a blue color for 3 countries, France, Spain, and Australia. These are compared to corresponding ground truth data depicted with red color. In our experiments, the source model was trained with data from the US. The transferred estimates are quite accurate, which is encouraging, especially when we consider the difficulty of the task that, apart from not using ground truth to calibrate the transfer, also involves search queries in different languages, all with very different temporal variations. We've also been working on disease rate forecasting models. Here are some preliminary results where we forecast flu rates in England 7 to 21 days ahead using Bayesian neural networks, but allow us to also include a confidence bound for our estimates. A key observation is that the inclusion of web search activity data improves significantly the accuracy of forecasts. This is ongoing work led by Michael Morris, who is a PhD student in our group. I believe it was around February 2020 when Public Health England asked us to provide prevalence estimates for COVID-19 using web search activity. All our previous work required some form of supervision, but COVID-19 was a novel disease and no meaningful data existed to do that. So we came up with unsupervised models for COVID-19. Here, the time series in blue depict the estimates from these models for 8 countries during the first wave of the pandemic. The black lines denote a refined version of these signals, where we are making an attempt to reduce the effect that news media reports might have introduced to these signals. We use this refined version as our proposed COVID-19 prevalence score. Here we align these estimated COVID-19 prevalence scores with confirmed cases. Confirmed cases are denoted with the dashed red line, and the solid red line denotes confirmed cases again, but shifted backwards to maximize the bivariate correlation with the COVID-19 prevalence estimates. It is almost clear that search-based signals precede reported cases, providing an early warning of approximately 17 days. In addition, the two time series mirror each other well when they are aligned. Their average bivariate correlation is, in this instance, greater than 0.8. And the same holds when you compare to deaths of people diagnosed with COVID-19. In that case, the early warning increases to 22 days on average, as expected, and the correlation after aligning the signal is slightly stronger. As part of the same study, we trained a supervised learning model, mapping search trends to cases for Italy, and transferred it to all other countries. Italy had a COVID-19 outbreak earlier than the other countries in our analysis, so we used that to inform models elsewhere. Here you can see a comparison between the unsupervised signals that you've also seen in the previous slides, depicted using red, and the transferred signals in black. The unsupervised models provide an earlier warning of about 5 days. In addition, though, the fact that the transferred estimates that incorporate some form of supervision from the data from Italy, when shifted backwards, have a strongly correlated trend with the unsupervised ones, provide some additional validity for our original results that were unsupervised. Now, moving on to a method for identifying web search anomaly patterns for specific COVID-19 related symptoms. This model asks the question, how much different from our expectation is the reported frequency of a symptom-related search term in a certain location? An expectation is formed by looking at reference or control locations. Whenever a reported search frequency significantly exceeds our expectation, a location is flagged for a potential outbreak. In the figure, you can see the area under the RO curve of such a system when using searches related to the symptoms of fever or cough as a function of how many days sooner our approach would have flagged an outbreak compared to the confirmed cases data that are reported by Public Health England. These experiments were conducted on data from local authorities in England. The accuracy of the system is respectable, and the amount of early warning potentially helpful for planning and policy making. A similar approach was deployed in previous work to estimate the impact of a public health intervention using social media and web search activity. The particular intervention was a pilot vaccination campaign against flu. The campaign was launched in just a few areas, so it was difficult to estimate its impact using traditional epidemiological data. In the figure, the red color lines indicate estimated flu rates in locations that vaccinations took place. I have just annotated 2 of them, indicating that they were targeting a small subset of London boroughs. And the black color lines denote projected flu rates had the vaccination campaign not taken place. We almost consistently see that reduced rates in locations, that participated in the pilot. Here is a qualitative analysis where we looked at time series of alcohol-related searches before and after the application of minimum unit pricing for alcohol sold in Scotland, a policy that aims to reduce alcohol-related ill health. We've seen the expected, that is an increased amount of searches around the date of the policy application, which was more pronounced in Scotland, depicted with blue, rather than in England, using red color. We've also seen potential attempts to circumvent the policy and buy alcohol outside Scotland, but we didn't observe any short-term positive impact during the first year of application. In another project, we used Twitter data to estimate the secondary attack rate, or SAR, of flu. SAR is the probability of infection following contact with an infectious person. Now, this is an important property that can inform epidemiological models. We estimate that by identifying relevant sequences of tweets. For example, a user can write that they got the flu, and after a few days write that a household member of theirs got the flu as well. We have now repurposed this work, attempting to estimate the secondary attack rate for COVID-19 variants and improve various modeling aspects as we go in this process. This is an ongoing project led by Thomas Chernuzenko, who is a PhD student in our group. Finally, this is perhaps one of the most challenging but also exciting projects we are involved in. In collaboration with consultants and academics from Imperial College Healthcare, with an expertise in gynecological cancer, we have commenced an innovative experiment that will assess whether web search activity could provide an earlier warning for gynecological cancers compared to the actual medical history of a patient. In addition to a potential earlier warning, we might be able to uncover a more consistent symptom profile for cancers such as ovarian, the late diagnosis of which is oftentimes attributed to a vague clinical presentation. For ovarian cancer, we know that the 10-year survival rate is 75% when treated at stage 1, as opposed to 21% and 5% when treated at stages 3 and 4, respectively. So early detection is key and very important. NHS Ethics has approved our study, and the team at Imperial has been recruiting patients since late 2020. To close this short presentation, I want to say a few words about impact and future research. Some of our research is already used by public health agencies. Our models for flu rate estimation from Google search activity are used by Public Health England as part of their surveillance tools and are included in their weekly reports. And by the way, based on our more recent estimates, you can see that flu circulation in England during the COVID-19 era was quite low. The same holds for our COVID-19 models. These are part of Public Health England's syndromic surveillance tools, and our estimates are included again in the weekly COVID-19 surveillance reports. Symptom-related web search anomaly indicators for UK local authorities are also sent to Public Health England on a weekly basis, thanks to the resilience of Microsoft Research that continues to support this effort. The overall impact of our work is also very well captured in our REF 2021 case study that includes very favorable testimonials from public health experts from the academia, Public Health England, and the World Health Organization. This pandemic provided plenty of proof that this line of research is relevant and useful. However, it also highlighted that many of our methods are not ready for immediate deployment. There are many more steps that we need to take. First, we need to continue integrating the many different data sources, novel approaches with more established ones, and also embed novel solutions into the policy-making process. Of course, the evolution of our AI solutions is essential, but we should also expand both in terms of exploring broader health-related themes, but also by getting more people involved into this up-and-coming research field. This is an interdisciplinary undertaking that needs educational refinements, both for computer scientists and for public health experts. But we should also educate our main participants, the online users. Who knows, one day we might not need to tap into their data using third-party organizations. Finally, at some point, we will need to regulate as well. These solutions feed from massive volumes of user data. User privacy needs to be always protected. And at the same time, public health systems will require an uninterrupted access to these data streams for developing practical solutions. There are many people and organizations involved in the research I presented today. I try to include everyone in this slide, but I would like to especially thank Ingemar Cox from UCL, Elad Yom Tov for Microsoft Research Israel, and Richard Peabody from the World Health Organization and previously from Public Health England for almost 8 years of great collaborative work and exploration of inspiring ideas. Our work led to the incorporation of novel tools such as the flu detector into Public Health England's syndromic surveillance, and that was a global first as far as I am aware, and I'm really proud for this achievement. I hope we continue on this research journey as members of the AI Center for years to come. And with that, I would like to thank you for your interest. I'm happy to answer any questions if there is time.
Yes, there is one question. Shall I read it?
Yep, maybe I'll try to stop sharing my screen and be able to read it myself, but yeah, please do for the time being.
Okay, it's from Supan and it says, does non-English languages affect model predictions? In other words, how robust the model is to language changes?
Depending on the model, I'd say. So if the reference is in relation to the transfer learning models, where we train the model in a country, an English-speaking country, and then we transferred it to another country, we've seen that the model was quite biased towards the quality of the translation, let's say, module. So we used cross-lingual word embeddings to do that. That provided quite a good, let's say, mapping. And also we need to keep in mind that it's not only about exact translation here, it's also about what people, for example, search based on their culture, and that can change from one language to another. So that's why we also introduced different components to that to optimize and transfer, which was comparing the time series of perhaps different search queries into languages before mapping them. So I'm not saying it's an easy task, but I'm saying that there are solutions into solving the language barriers in most of our case studies so far.
Okay, thank you. If there are no more questions, then we will pause until 11:30, at which point I hope Max will be here for his presentation.
Thank you very much.
Thanks.